Welcome back. Today, we're going to trace the journey of a local anesthetic all the way from the tiny molecule itself to a full-blown code blue clinical emergency. We're going to connect the dots between pharmacology and that crash cart so you know exactly what to do when things really hit the fan. So, let's kick things off with a real high-stakes question. Imagine this. You've just done a nerve block. Your patient suddenly starts to seize. What is the one induction agent you absolutely have to avoid? Now, hang on to that question, because I promise by the time we're done here, the answer is going to be burned into your brain. Okay, so to really get a handle on the crisis, we got to start at the beginning. I'm talking about the tool itself, the local anesthetic molecule. It's actually a pretty elegant design, but that elegance is key to both how well it works and how dangerous it can be. What's so cool here is how a super simple trick, just counting the I's in the name, tells you almost everything you need to know. It all comes down to a single chemical link. Is it an amide or an ester? The amides, they've got two I's. Think lidocaine. They get broken down by the liver, so a true allergy? Super rare. But the esters, they only have one I. They get metabolized right into plasma, and one of their byproducts, PIBA, is a known troublemaker when it comes to allergic reactions. So here's the absolute key to how these things work. They don't just sit on the outside of the nerve. Nope, they actually have to be sneaky and diffuse inside the nerve cell to get to their target, which is the voltage-gated sodium channel. Once inside, they basically act like a plug. They physically block that channel, stopping the electrical pain signal cold in its tracks. Simple, right? No signal, no pain. And this right here, this is the perfect example of the double-edged sword with our most potent drugs. Take bupivacaine. It's super lipid-soluble, meaning it loves fat, so it just slides right into the nerve membrane, no problem. That's great. It makes it more potent and it lasts a lot longer. But, and this is a big but, that exact same property means if it accidentally gets into your bloodstream, it's going to slip into your heart cells just as easily. And it doesn't just bind to those cardiac sodium channels, it binds to them with a vengeance, which is why its risk for cardiotoxicity is so much higher. All right, so we've got the molecule down. We know how it works on a cellular level. But what does that actually mean for the nerve itself and for the patient? Like, what's the sequence of events here? Well, the way a block sets up is actually super predictable. You can almost set your watch to it. The very first things to get knocked out are the tiny sympathetic B fibers. This causes the blood vessels to open up, which is exactly why the first sign you look for, that first clue of a successful block, is a warm, maybe slightly flushed limb. After that, you'll see loss of temperature and sharp pain, followed by touch and pressure. And the very last thing to go, that's your motor function. And guess what? It's also the very first thing to return when the block wears off. Okay, now here's a really important update. Sort of a myth buster for something you might have learned from an old textbook. We all used to be taught small fibers get blocked first. Simple. But it turns out that's not the whole story. We now know that those unmyelinated C fibers, the ones that carry dull, achy pain, are actually pretty resistant. The clinical sequence we actually see in practice isn't just about fiber size. It's really driven by the nerve's anatomy, things like myelination and how far apart the nodes of Ranvier are. Okay, so let's take all this pharmacology and apply it to a couple of really critical areas. We're going to look at neuroaxial anesthesia in the spine, and then we'll move to peripheral nerve blocks for the shoulder. When you're doing a spinal, the needle you choose makes a huge difference for your patient's recovery. Think about it. A Quink needle has a cutting bevel. It literally slices a tiny hole in the dura, and that can lead to a really nasty post-dural puncture headache. But contrast that with a Whitaker needle. It's got a pencil point tip, so it doesn't cut. It gently separates the dural fibers, and when you pull the needle out, they just close back up. It's a tiny difference in design, but it massively drops the risk of that headache. Now, in the world of pediatrics, the caudal block is an absolute workhorse, especially for surgeries below the navel. But there's a huge anatomical trap you have to know about. In neonates, that dural sac, the one full of spinal fluid, ends way lower down, sometimes at S3 or even S4. And that puts you dangerously close to accidentally turning your caudal block into a massive total spinal. It's exactly why careful aspiration and using an epinephrine test dose are absolutely non-negotiable safety checks, every single time. Let's talk about shoulder blocks. For a long time, the interscaling block has been the gold standard, right? The king of pain relief for shoulder surgery. And it works. It provides amazing, dense pain control. But it comes with a massive and pretty much unavoidable side effect. And here it is. That side effect is a nearly 100% incidence of paralyzing the phrenic nerve on that same side.
Think about that. You're knocking out half of your patient's diaphragm. Now, for a healthy person, they can usually handle that just fine. But for anyone with severe COPD or any kind of compromised lung function, this block is an absolute no-go, completely contraindicated.
So what's the solution? Well, thankfully, newer, smarter motor-sparing blocks have come to the rescue. The whole idea is to target only the sensory nerves, much further away from the phrenic nerve. Techniques like the suprascapular block, for example, give you fantastic pain relief that lasts 24 hours or more, but with pretty much zero effect on the diaphragm. It's a game changer for making these procedures safer for those at-risk patients. But what happens when things go horribly wrong? When that local anesthetic you so carefully placed near a nerve gets into the bloodstream and floods the whole system? Well, that's when you come face to face with one of anesthesia's most feared complications, local anesthetic systemic toxicity, or LAST. And last happens fast. I mean, terrifyingly fast. The central nervous system is more sensitive, so it gets hit first. Your patient might say they have a weird metallic taste or ringing in their ears. Then comes agitation, and then, boom, a full-blown tonic-clonic seizure. As the drug continues to circulate, the cardiovascular system goes down. You'll see it progress from a high heart rate to a dangerously low one, and then, ultimately, to cardiac arrest. And if there's a classic villain in the story of LAST, it's bupivacaine. Remember how we said it's super lipid-soluble? That lets it get into cardiac sodium channels incredibly fast. That's the fast in. But here's the kicker. Once it's in there, it grabs on so tightly that it lets go very, very slowly. That's the slow out. And that fast in, slow out mechanism is what makes a cardiac arrest caused by bupivacaine so notoriously difficult to treat. So the second you even suspect LAST, you have to move. And I want to be really clear about this. You have to throw your standard ACLS playbook out the window. This is a different beast. It requires a specific aggressive protocol designed to fight a specific poison. So here's the protocol. First thing, call for help and get that airway secure. If the patient is seizing, you're going to use a benzodiazepine like midazolam. And now here it is, the answer to that question from the very beginning. You must avoid propofol. Yes, I know it treats seizures, but it's also a major cardiodepressant, and it will just pour gasoline on the fire. The definitive treatment, the real antidote here, is intravenous lipid emulsion. The theory is that it acts like a lipid sink. It literally sponges up the fat-loving anesthetic, pulling it right out of the heart and brain tissue that it's poisoning. And this might be the single most important difference from a standard code. In a normal arrest, you're pushing 1 milligram of epinephrine. Do not do that here. Those big doses can actually trigger deadly arrhythmias and make the situation worse. In a LAST arrest, you have to use tiny doses. We're talking 1 microgram per kilogram or even less, just enough to support blood pressure without further poisoning an already unstable heart. Okay, let's switch gears. Time for some rapid-fire emergency decision-making. We've been laser-focused on local anesthetics, but other emergencies can pop up. So you're in the OR, you suddenly see the patient's end-tidal CO2 shooting up, and their jaw muscles are rigid. What is it, and what do you do first?
That's it. Classic malignant hyperthermia. Your immediate actions: stop all triggering agents, yell for the MH cart, hyperventilate the patient with 100% O2, and push the antidote, dantrolene.
All right, next one. This is straight out of what we've been talking about. You just finished an intrascaling block, and minutes later, your patient has a tonic-clonic seizure. What's your top priority? You got it. That is LAST until you can prove it's something else. Your priority is simple. ABCs. Secure that airway. Treat the seizure with Medzolam, not propofol. And then get that intralipid bolus in immediately. Honestly, knowing this one specific protocol, what drug not to use and which antidote to give, can be the one thing that stands between a full recovery and a total disaster. And it really makes you think, doesn't it? What other standard protocols do we follow that might need a complete rethink when a specific toxin is in play?